Welcome to today's webinar resident series, Getting the Edge on Removables. It is being presented by Tremaine Watkins, CDT, Clinical Director of Guided Surgery Implant Solutions. Now it is my pleasure to introduce Tremaine Watkins, CDT, Clinical Director for Guided Surgery at National Dentex. Tremaine has been working in the dental lab industry for more than 30 years. After graduating with a Bachelor of Arts from the Trinity College in Issaquah, Washington, as class valedictorian, he has gained extensive experience in all aspects of fixed and removable restorations, with an emphasis on implant-supported and retained restorations. He also has provided clinical support in case planning, troubleshooting, and implant placement. He has trained with other technicians in all aspects of dental technology and has written and lectured in several aspects of restorative dentistry. Take it away, Tremaine.
Thank you, Jessica. Well, thanks everybody for joining up today. I think you'll find this very interesting. We're going to focus on, we'll cover basic denture techniques, but we're going to talk about some of the newer workflows that are involved to make it more straightforward for you. So here we go. There are a lot of people that are missing their teeth. I'm sure throughout the residency program, you guys have seen this, but this last statistic is very interesting, I think. 174 edentulous people for every general dentist in the United States. So dentures can be a big part of every practice. So when we talk about this, I think the next step is to think about where is the revenue. So we could be doing, if you think of single crowns as your baseline, because for most practices, that's kind of a big part of what they're doing. You're doing 31 million of those. So by contrast, you could be doing a quarter of that business by working with dentures. And in a lot of practices, this really isn't a big part of the practice. So what we're hoping to do today is kind of give an overview. I'm sure some of this will be things that you've already covered in your residency program, but kind of put it all in one place to be more helpful for you guys for doing dentures with your patients. So we want to talk about occlusion and articulation because this is so important for dentures. As you guys know, one of the major challenges for denture wearers is stability, that hopefully that their dentures stay in, that they're solid, that they don't overload given parts of the ridge and increase resorption. So occlusal scheme is critical with dentures because of the profound effect on stability. While your lab will usually set or design the occlusion on your dentures, a thorough understanding of tooth position and denture occlusion will help you coach and evaluate your laboratory. First, we're going to start with a couple definitions. Occlusion is defined as the way the teeth come together in a static position, such as swallowing. Articulation refers to a dynamic tooth relationship while chewing. Edentulous and dentate patients articulate differently. Denture wearers tend to chew horizontally with only a slight vertical component, while dentate patients, as you guys know, tend to chew in a warped teardrop pattern with much more vertical movement. As we'll see, this different articulation requires different patterns of tooth contact. Many denture wearers are frustrated by the instability of their prosthesis. By the way, studies have shown that about 90% of people who wear dentures are dissatisfied with their denture. So there's a real opportunity to provide some needed and effective treatment for your patients. Obviously, the fit of the denture is very important for stability, but we also want to talk about how the way we design our occlusion is going to directly affect how stable the denture feels when the person is functioning. Denture occlusion, like I guess most things in dentistry, can be a controversial subject. Historically, bilateral balanced occlusion, in which all the posterior teeth contact on customers' ridges in all possible movements, was kind of seen as the gold standard of denture occlusion. And there were a lot of techniques and tooth designs to facilitate this. One of the challenges is that when you actually go to set a case in bilateral balance, you need the case mounted with a face bow, and it is very difficult to do. And I heard somebody talk on it once, and I think they said there's 42,000 possible combinations or tooth positions when you're trying to set bilateral balance, which makes it very difficult in real life. And a lot of times what happens is that then you, in actual function, a case that was designed in bilateral balanced occlusion actually winds up having inconsistent occlusion. You know, you might have one molar functioning in this particular movement, and so creating, again, tipping forces that we're trying to avoid. For this reason, lingualized occlusion has become much more popular in recent years. Surprisingly, despite the differences in cusp morphology, in vivo studies have shown that these occlusal schemes have similar chewing efficiency when you're actually using them, but when patients have the opportunity to do double-blind studies of these occlusions, they find that the lingualized occlusion has feels more stable in function. You can use either of these schemes with patients with a substantial ridge. If you have severe atrophy, probably lingualized occlusion will be better. The difference between these two is, as you can see, the cusp angle of the mandibular posterior teeth. When you classify posterior denture teeth, as you guys know, they're organized by the angle of their buccal and lingual cusp planes to a relatively flat plane. The most common ones are 0 degree, 10 degree, 20, 22, 33, and 40. Usually teeth with larger angles look more aesthetic. However, with the aforementioned flat chewing motion common to most denture wearers, teeth with higher cusp angles also tend to create excessive lateral interferences, which can lead to tipping of the denture. It's better to avoid, for full dentures, teeth with cusp angles of more than 22 degrees. If you're doing a bilateral balance case, you might do 22 teeth on both the upper and the lower. For a lingualized occlusion, however, you do a 22-degree teeth on the maxilla with 10 degree on the mandible. As you can see, A here is our bilateral balanced and B is lingualized occlusion. So when you're setting your anterior denture teeth, we'll first consider aesthetics and move the teeth from that position to create slight anterior disclusion and symmetry while having even contact and articulation. So we want to make sure that that we follow this rule so that people are happy with their teeth position. So we want to have 1 to 2 millimeters of incisal edge display when the person's lip is at rest. That often looks youthful. We don't want more than 2 millimeters of the pink denture base, the gingival replacement, showing during the very high smile. We want our lower incisors to follow the lower lip at rest. Want the dental midline parallel to the facial midline and the incisal angle parallel to the interpupillary. And then if you're trying to, this image on the bottom right here, if you're trying to set teeth and you don't have a denture, in general, if you set the labial aspect of 8 and 9 flat to the front, 8 to 10 millimeters labial to the center of the incisive papilla, you'll generally get a very nice position. One thing you can do to validate your anterior tooth position is check fricatives. You should get contact at the wet dry line on the incisal edge of the maxillary anteriors when they're in the right position. With our anterior teeth, we don't want them to touch in centric, whether this is a single or a dual arch denture case. However, as soon as the patient articulates, we'd like to have all the teeth, all the anterior teeth in contact. A lot of times the best way to do this is to set the overlap, or the overjet and the overbite, to the same number. So 1 millimeter is really popular. Sometimes people do 2 millimeters. In general, though, you want the two numbers the same. We don't want to set dentures in class 2 occlusion because that's going to create quite a bit of tipping force in the anterior. So when we're talking about anterior teeth, obviously we're concerned about aesthetics and function. With posterior teeth, we really want to focus on function. The first thing is that we have to set our posterior teeth over the crest of the ridge. As we move the posterior teeth off the ridge, we're creating a lever that again creates tipping force makes the denture unstable and makes our patients less satisfied with our results. When we set a denture, in some ways it's easy to think, oh, I can put the teeth wherever I want, but we really can't. If the ridges are class 3, we have to set the teeth class 3, for instance, or else the patient won't get the stability they need. When we're doing double arch cases, we want to make sure we get our occlusal plane in the correct position, which will help with our stability and especially in articulation, make our teeth function better. You can help your laboratory out with lower dentures, especially with double arch. Make sure you capture the whole retromolar pad in your impressions, which can be a little bit difficult. Sometimes you even need to, if you're using a stock tray, put a little bit of compound back there to help extend the tray far enough coronal to capture the whole retromolar pad. And the position of the maxillary posterior teeth is probably the most important for stability. We want their central dissectional groove, which is where the maxillary lingual cusp will line up, centered on the mandibular alveolar ridge. Also for tongue space, a good general rule is we don't want to set our lingual molars the linguals of our lower molars any further lingual than the mylohyoid ridge. In general, that will give the tongue space that our patients need. A couple other things when we're looking at where our posterior teeth go. In general, we only want to use 2 molars. Even if there's room for third molars, we usually leave them out with dentures to help with cheek biting. And then we don't want to bring our mandibular posterior teeth up the ramus or to go over the maxillary tuberosity with teeth. In general, we just want to put our pink resin back there. So in general, we want our fully balanced occlusion. This doesn't necessarily mean that we do bilateral balanced occlusion, but it means that when we're setting up our lingualized occlusion, we make sure that that our teeth contact evenly on both sides of the arch in all articulations. We definitely want to run through that on our articulator. And then validate it with marking paper in the mouth. We want to look at our patient's occlusion. So when you're evaluating your denture patients, ask them to simulate chewing for you, because then you can kind of see if their movement is pure side to side. You may want to do flat teeth on both arches, 0 degree, in other words, just so that those cusps aren't forcing their jaw more open than they would naturally move. Denture borders are critical for stability, as you guys know. And so I want to review the important anatomy just so that you guys know, what needs to be picked up in the impression. And then especially on the mandible, we want to make sure we don't extend our dentures too far. And this is an area where you can really help your laboratory. Sometimes our technicians aren't quite as experienced as you guys are with looking at tissue and saying, okay, this is mobile tissue. I don't want to cover this with the denture. Whereas this is stable tissue on bone, and we want to make sure we cover all that to spread our occlusal forces and avoid sore spots. For the maxillary denture, our prosthetic should cover the tuberosities into the hamular notch. They should extend into the buccal and lingual vestibules, avoiding the frene, and staying about 1 millimeter above the vestibular border. On the palate, they should extend to the vibrating line. Sometimes on the model, we can see the vibrating line because of the difference in texture, but a lot of times if you'll use a marker and mark in the mouth in a way that picks up in the impression, that can be really helpful. Or just mark it right on the impression itself. Your skill in marking that can really help your laboratory. As you know, mandibular dentures, the borders are even more important. We want to cover the apical half of the retromolar pad, extend out onto the buccal shelf, and then again, 1 millimeter shorten the labial vestibule, avoiding the frena and the mentalis muscle attachments. On the lingual, we want to stay above the mylohyoid ridge in the posterior, and then avoid the lingual frenum and slightly out of the vestibule. So for your laboratory to make a nice, stable, accurate denture, you'll need to make sure you capture all of these landmarks so that way your patients get the proper attention. So we want to talk through, boy, that's a little bit blurry. We want to talk through the analog denture process. We're going to be focusing on digital today, but we'll talk about the analog because that's kind of our point of reference. So the optional first appointment is to take a study model for a custom tray. You can take these with alternate if you like, as long as you or your laboratory can pour them quickly. And your second appointment will capture the master impression. You want to make sure that the tray that you use fits well, both that it doesn't impinge on the tissues and that it doesn't have huge space underneath that's going to require a lot of impression material, may create inaccuracies in your impression. You'll want to make sure that you can capture all those anatomic features that we've discussed a minute ago with the tray that you have and when you're taking your master impression. You'll want to take your opposing at this time. So once your laboratory gets the impression, they'll pour it up, make nice models for you, and then make bite blocks. A lot of times we forget that bite blocks are more than just a way to hold the two arches apart. When we take a little bit of extra time with the bite block, it basically is our setup in wax. So we want to make sure that we contour the labial surface for correct lip support. And we want to make sure that the buccal surfaces are shaped well also to kind of give the correct buccal corridor so we don't have too much negative space at the smile. We want to set the incisal edge here on the maxilla, and with that correct tooth display, we can mark the midline. This horizontal mark is the high lip line. So your laboratory knows that the teeth should extend 1 or 2 millimeters from there. You can mark the cuspid eminences. You can see that a lot of data comes in on the bite block. The more time you take getting the bite block the way it ought to be, then you'll find that your setups get a lot more predictable and you're less likely to have to do resets. So when you send in your bite blocks, your laboratory will go ahead and articulate the case, and then they're going to set the denture teeth in wax in the same position that the buccal surface of your bite block was. They'll set for the occlusal scheme that you describe and proper aesthetics, et cetera, and they'll send you the teeth on those same base plates to evaluate the aesthetics, occlusion, articulation, phonetics. Because the teeth are set in wax, the patient can't function on this try-in, and fit can be a little bit of a challenge. To make a bite block on a model, us laboratories have to put a little bit of block out on there. So you kind of have to use your judgment. The denture base should fit fairly well, but not perfect. If you're not sure, if you're like, I don't know if this is good enough, go ahead and take a reline, paint some impression adhesive and take a reline inside the denture base because you want to make sure that the case fits well. So your lab will make any necessary adjustments to the setup, then process the denture. This fifth appointment is usually, this is when you can finally evaluate the denture. You want to make sure that it's comfortable, that it seats fully, that the extensions are correct, and you got even occlusion, both in centric and articulation. If the prosthetic doesn't fit well, you may need to reline your new denture. One of the challenges of making analog dentures in the laboratory is that the teeth can move. So sometimes, even if the setup was perfect, and even if the proper procedures were followed, your aesthetics or your occlusion may change a little bit. And I think that's one of the worst things for those of you that have done a lot of analog dentures with the analog process, is that everybody can do their best, but sometimes things just happen that make the thing unpredictable. The current denture workflow was perfected in the 1950s, and it can work seamlessly. Every once in a while, we get a case finished in 5 appointments that we discuss. However, if you think dollars and cents, of 45-minute appointments at an average of $6 a minute creates $1,350 in office fees in addition to the lab fees for the denture. at the current levels of reimbursement, this process just isn't profitable. And that's best case scenario. If you start adding unpaid extra try-in or adjustment appointments, you can see that a lot of offices kind of steer clear of dentures. You can wind up doing a lot of adjustments. You can have teeth delaminate, you can have breakage through the palate, different things like that. And the worst is a lost denture. You know, you've done all this work, you've gotten a denture that works perfect, and the patient comes in and says, oh, I lost my denture, I need another one. And it can be so demoralizing because you work so hard and then you're starting from scratch. So I think because of this, the digital process is more attractive because it helps address some of these concerns. So dentures are retained by a precise fit to the tissue, and that creates what we think of as suction. So all acrylic resins that are used in the analog denture process have a curing shrinkage of 8%. There are different processes like injection that have been in creation of post-dam to compensate for the shrinkage. But despite all that, you're going to have a certain amount of fit inaccuracy that affects not only the retention, but also hard and soft tissue health. As you know, when we overload local areas, the bone's going to tend to resorb. In reality, a well-made analog denture doesn't fit perfectly on day one. On the other hand, digital dentures are, when they're printed, they're cured in 50 micron sections, so they get a near perfect fit, as shown in the graphic on the bottom right. So on these two images down here, the green is the areas where in an in vivo study, the denture actually adapts perfectly to the tissue. And you can see with a CAD/CAM prosthetic how much more even that is. A couple other things where a printed denture can be helpful for you guys is the way the teeth are attached. Whether the teeth are one piece of PMMA that's milled or printed, or if they're carded teeth, they're bonded with a composite material when they're installed. So it's very difficult for teeth to debond. There's also no wax involved in the process. With the analog process, you have to clean the wax off, and if there's any stuck, it works as a separating agent. With this, the teeth are placed in clean the way they're manufactured, so you get a much better bond. One of the things too that I was kind of surprised to find out is that the best analog denture resins have a flexural strength of about 79 newtons. Lucentone digital print, which is the printing material from Dentsply that's kind of revolutionized printed dentures, has a flexural strength of 200 newtons. So this is going to help you prevent that breakage that can be so frustrating. Digital dentures are relatively new, but some early studies are showing that they seem to be more resistant to staining than traditional packed or infected dentures. And last but not least, you can save your denture file. A lot of your labs generate hundreds or thousands of design files relatively rapidly, and so just from a storage perspective, they need to get rid of these files fairly quickly. So if you ask your laboratory, they can give you the digital denture file. Say, I'd like to save enough files to be able to remanufacture the case. And then if you save the records of what was used, in other words, if it's using carded teeth, you need to know which teeth were used and what resin. And then if a denture is lost or broken or whatever, you can share those files with your laboratory and ask that the case be reprinted. One other thing to keep in mind is continuity with the digital process. There's no boil out the wax and try to process it. It's that we take the digital file and we manufacture it in different ways. So there's very much continuity from the impression to the try-in to the delivery. We're going to talk about a couple different workflows that you can do. A lot of times I think when people hear digital, they're like, well, if I can't do it with an iOS, I can't do it. But there are some hybrid analog digital workflows where you can still do analog records and a digital denture. We want to talk about taking a physical impression, doing a digital denture. We can talk about a couple different ways of taking digital records, both with an edentulous scan or a reference denture workflow. I think for most people, the reference denture workflow is the gold standard today for digital dentures. And 80% of your patients have some kind of denture. So you can make sure they bring that and tell them, we'll just use it as a baseline and we'll make you a nice new denture. There is a very advanced workflow using a facial scan that gets you down to 2 appointments. And so we'll talk about that a little bit. All right. The first couple appointments for the analog to digital workflow are going to be the same as those for an analog denture. You can do your custom tray and then your master impression. You'll need to use your normal border molding procedures because the fit of the digital denture, although it's better than an injected or packed denture, it's only as good as the impression data that you give. So you still need to do your border molding and all those things to make sure that we get a good impression. So one of the things to keep in mind, as you guys know, anytime you're dealing with full arch dentistry, including dentures, one of the most difficult things is getting the bite. So if you have a patient who is edentulous and you're doing analog records, you can do what's called a mush bite. You take some kind of putty, suitable for intraoral purposes, mix it up, make a roll, put it on the edentulous ridge, and then just have the patient bite down until they've reached their correct VDO. As you can see on this, you can mark your midline, your high lip line, all the things that you would normally mark on the mush bite. You want to make sure that as it's polymerizing that you shape it up so it doesn't push the lip out too far, because essentially you're making a putty bite block for your laboratory. Using this technique, it takes a little bit of practice to get good at it, but using this technique can avoid the bite block appointment, so you can send an impression and a bite for a first appointment, so that way you could go straight to try-in if you want. If you don't want to do the mush bite technique, your lab can go ahead and pour a physical model and make bite blocks just like you would with the conventional technique. That'd be your second appointment. So you go ahead and do everything you do for a conventional denture, because again, your bite block is going to be the template for the setup. This is when it starts getting different though. Back in the laboratory, your technician will articulate your master model and your posing. And then the master model, the posing, the bite, and the bite block or mush bite are scanned. Your lab will use the bite block in 3D space as a reference for tooth position. Tooth will be designed in the correct position, the borders of the denture set, a gingiva designed, and the two files will be merged. The resultant tooth color prosthetic will be either printed or milled, more about that later, polished and sent to your office. The nature of the try-in appointment changes dramatically with your digital dentures. First, the fit is the same as the denture. We don't have to do any block out that's different for a printed base as we would for the actual printed denture. So you can verify your fit and your borders at this appointment. You can actually tell the patient, hey, let's do a test drive on your denture. I'm going to go ahead and send you home with this for a day or two. Why don't you wear it and let me know what you think? As shown in the photo here, you can make adjustments to this denture. Let's say, like on the left side, the posterior teeth are hanging down a little bit, grind them off. You can mark things with a Sharpie as you've seen here. You can set the borders. Make sure you make a note on your prescription of whatever adjustments that you make so that your laboratory knows what needs to be done. If you're making huge adjustments, you definitely will want to do another try-in. If they're small adjustments, they should be able to be made predictably from the try-in to the final. If you're not sure whether you need another try-in or not, and you want to decide before the patient's there, make sure you give your laboratory a call and talk about what changes need to be made. So if there are any changes to print and try-in, your lab will scan it as a reference. If you had to reline it for some reason, we can pour a new model, scan it, and align it using the reference denture, the denture, sorry, as the orientation technique. Once a case is altered as prescribed in the design software, your lab will digitally manufacture the case. Labs can either use carded teeth that are specifically designed for digital dentures, or they can mill and print teeth. Milled or printed teeth allowed cases to be made even with limited occlusal clearance, so they're probably the best option in 2023, but talk to your lab about their most successful workflow. When you get the digital denture, you'll check the fit and bite. Sometimes you can have a more successful denture if you put cotton rolls on the posterior occlusal surface, ask the patient to bite down for about 5 minutes before you evaluate the case. This is where digital really shines, because the process has an intrinsic consistency to it. In other words, the same design that was used, the case didn't have to be redone between setup and finish. The same design that was used for trying is just modified and is actually used to deliver the finished result. I was talking to a dentist who loves doing these and has kind of oriented his practice towards doing mostly dentures. And he said, I just love digital. He said, I love giving people a nice set of teeth. He does some implant placement and locators on some of them, different stuff like that. But he said, it's just so predictable. He said, I know that when I get the try-in, I know that the changes that I need will be made predictably, and I know that my insertion appointments are going to go well. So what if you want to do a digital impression? This is definitely an area where the technology that you're using makes a big difference. The latest generation of iOS systems are able to effectively capture tissue impressions. But there's a couple caveats in this. One is that you need to keep the tissue stable during scanning, especially in the vestibular area and stuff like that. So when you're working with your assistants, make sure that they hold the tissue in the correct position before you start scanning, then go ahead and do your scan. As we learn more and more about iOSs, we learn that scan path is probably the most important thing in getting iOS accuracy. And this is for anything, single teeth, bridges, scan bodies, whatever. But when you're doing dentures, it becomes even more important because you're pushing the limits of what the scanner can do. This is a scan path from an Italian prosthodontist, Dr. LaRusso, and it's been shown to be very effective as kind of a general way of scanning for full arch edentulous cases. Once you've taken the edentulous scans, you can either take a mush bite or have a bite block made. Then the workflow from that point will be the same as the analog digital workflow we just discussed. So let's talk about the reference denture workflow. I think for most of you, if you want to do digital dentures in your practice, this is the one that most people are using. This is the one that Jimmy Stegall is lecturing on, if you've seen any of his lectures. Again, statistically, 80% of your patients will have dentures. They may not be wearing them. They may be sitting in a vial of water at home, who knows, but you need to get them to bring their denture in, because you can go ahead and use that as basically your custom tray and your bite block. And I feel free to explain that to your patients, because I'm sure they'll be afraid, well, I hate that denture, it doesn't fit. No problem, I can take care of that. I just need a plastic chunk that I can use to get the records that I need. You will be returning the denture to your patient, so even though you may need to use some adhesive, keep in mind and make sure you have a good method for getting that back off. So the first thing you need to do is check your borders and make sure that you don't need to apply a little bit of compound. With this case, the doctor found that the retromolar pads weren't fully captured, and so the doctor put in a little bit of compound to give support in that area. So then you'll paint the intaglio surface with adhesive and use a heavy body material, and you want to do border molding. I want to go through that really quick just so everybody knows kind of how you do that. In the maxilla, once you've put your heavy body material on the borders like this, you'll want to go ahead and hold the denture on the palate with your finger. Give it some medium pressure. And then you want the patient to open and close while you're holding the denture, move their mandible from side to side, show a really high Duchenne smile, then pucker. If they go through those movements, their mobile tissues will shape up the border. On the mandible, you'll need to, of course, hold on both sides of the occlusal surface, but you want the patient to pucker first, then do their high smile, their Duchenne smile, then stick their tongue out and move it from side to side before closing and swallowing. Then you'll just go ahead and hold the denture while it's set. Go ahead and apply a low viscosity, meaning a light body material over the entire internal surface of the denture. Go through your border molding motions one more time while the material is setting up. It's best that you hold the denture as opposed to having the patient hold it with bite force. That way you know you're applying enough pressure to keep it seated, but not so much that you're distorting the tissue. You want to check your denture for stability at this point, because it should be stable with your impression reline in there. You want to look at the aesthetics and note any changes that your laboratory will need to make, and then note the current bite. Now that you have the denture in there, you can check and see, is the person, like this patient, a little bit overclosed? No problem. Get your leaf gauge and set the appropriate number of leaves to hold the bite open where it needs to be for vertical dimension. And then I would recommend putting a PVS material in each side of the arch to capture that bite, so you can get back to it later when you're doing your scan. So now you have a reline denture and a bite. So you're going to capture all this data with your iOS. So the first thing you'll want to do is take your denture without the bite and scan it 360. So you can scan the occlusal, buccal, lingual, and intaglio surfaces, creating a three-dimensional representation of your reline denture. Then you'll put the case back in the mouth and you'll scan the opposing, and then you want to put your bite in and scan the bite. Make sure that the software correctly orients the two arches. You can do this workflow with the mush bite as well if you want. You do the mush bite and then you reline it. It's a more advanced workflow, but it can give you a way to do this 3-appointment denture for patient workflow for patients without a denture. Of course, you can do the digital, scan the arch, do a bite block, and do the 4-appointment hybrid workflow that we were talking about a minute ago. So once you've got those scans done, what happens in the laboratory? Your lab will accept the case files, then design the new denture. I thought you might find this screenshot kind of interesting. This shows in 3Shape software how you use the purple is the patient's reference denture, and the beige is the design teeth. So you can see how your technician is actually using the existing teeth as a guideline. And then, like, as you can see on the posterior right here, the lab's made a slight adjustment to make the occlusal better. Facial scanning. So I think that we're right on the edge of another, I'd say, digital breakthrough with digital records. If you think about it, everything that you send to your laboratory is a proxy for the patient's face. So if you send a bite block, you're saying, I think that this will properly support the patient's face. Send a study model, you say, this thing looks good in the patient's face. But what if we could take a 3-dimensional scan of the person's face and actually design the teeth within the face? I think this is, like I said, this is where we can really advance. So when you do a facial scan for a denture, the lab is actually doing the denture design within the person's face. So normally you'll scan relaxed lip position, normal smile, high smile, and retracted. And so all those files are stacked on top of each other, and you and your patient, if you want to share it with the patient, can actually see the tooth position relative to the face. If you want with this workflow, you can definitely do a printed try-in. but I think what most of you will find is that the virtual try-in, the case looks the same. Let me go to the next slide here, because this is kind of what happened. So you digitize the patient, oops, over here. You digitize the patient, you design, and then when the case is delivered, it looks the same as the design. So you and the patient can review the case in the free, like ExoCAD viewer or some other 3D viewer, and get a good result with that. So your laboratory, just like you have materials that work best in your hands, your laboratory is going to have a workflow that works best for them. When digital dentures first came out, milling was kind of the preferred workflow because milling is very, very accurate. The main problem is that milling PMMA is very time consuming and it's hard on the equipment. So it uses up quite a bit of your milling capacity. The other thing is that sometimes in the maxilla, you have really deep undercuts that are difficult even for a 5-axis mill to hit. The first generation of 3D printed denture materials were kind of soft, porous, and weak. So you'd see a few people doing them, but they weren't really viable because the materials weren't there yet. With the introduction with this new generation of printed materials that meet or exceed the strength of an analog denture and getting excellent aesthetic results, I'd say that from a theoretic perspective, at least, the pendulum has swung towards printed dentures. Printed dentures are faster. There's not all the waste that there is with a puck you don't use. For printing, the wear and tear, it doesn't matter what you're printing, the wear and tear is the same. So it doesn't beat up the equipment near as much as milling does. And it tends to be more predictable. You don't get broken tools and stuff like that. So I'd say that from a theoretic perspective, printing is the way to go in 2023, but do talk to your laboratory and find out what they're getting good success. It's possible to do a copy denture. If you have a patient that really, really likes their denture, but they just want it to fit a little bit better and they want it renewed, you could do a quick impression reline using that reference workflow and send that into your laboratory and ask them to make a copy. Now, keep in mind that most lab software doesn't have the biocopy function, similar to what you see in CEREC. So it'll be very, very close. But if you have those patients that want it to be exact, let them know there may be millimetric changes here and there. Good to know it's available, probably not a huge market. Immediate dentures. There's a great digital workflow for that. You can go ahead and scan the person, their current dental situation, and then set the bite where you want it, scan the bite, and send that into your laboratory. One thing that you could really do to help your laboratory with immediate dentures is kind of talk about how much of the model you'd like removed with the virtual extractions. What I usually recommend is removing just to the free gingival margin at each tooth. The reason being that I think it's better when you're delivering the case to have a little bit of space than to have it a little bit tight and have the denture rocking. The thing to keep in mind as you're pricing these out and planning these cases is that immediate denture that you use, you can then do the reference denture workflow and use it to make a final denture. And if the tooth position's good, you don't even need to do a try-in. You can just do reference denture scan and delivery to make your immediate dentures much easier. One other nice use of printed dentures, digital dentures, is printed overdentures. With the extra strength that you have in the material, it can be a great product for doing your locator type overdentures. Also, locators come out with a little scanning cap that you can put on the attachment. It's designed to facilitate chairside insertion of the male component. What it'll do is it'll create a precise space inside the denture so that you can easily cure your attachments. Well, that's it. That's all I have today. Thank you very much for listening. I hope you've learned some interesting things about dentures and especially digital dentures as you're looking to add that to your practice.